So this is the model, okay. So basically at day 0, parasites are injected intraperitoneally. It's like 4 times 10 to the 4. And then at day 21 days, they invade the CNS. You treat, this was developed by Frank Jennings, who was a great pioneer in Glasgow. He died recently. And he treated with this drug, Beronil, which is given for animals. And this, in some way that we don't actually understand, causes an overshoot. Somehow what happens is the parasites are cleared from the vascular component, but not from the brain. And they get sick, and then you give another dose, they get even sicker, and the pathology is exactly the same, identical to human disease. This is completely reproducible. This has been used as the standard preclinical testing of drugs for sleeping sickness for the last 30 years. This is 10 years' work summarized in 4 lines. Basically, astrocytes become activated between 14 and 21 days post-infection before the inflammatory lesions appear. Therefore, the response is not secondary, and a whole variety of pro-inflammatory cytokines, in particular the ones which are important, are TNF-alpha, IL-1, and also interferon gamma seems to be very important. And this, in fact, just shows a study that we did that as the animals get worse, the brain disease gets worse, then interferon gamma goes up, and TNF-alpha goes up, and IL-10 also goes back. So we think that the disease, at least in part, is a consequence of a balance between pro- and counter-inflammatory cytokines, and we think IL-10 is critical. We've been looking at various things over the time. Azathioprine, obviously would never give that in the field, but that has been used to prevent, not ameliorate. The DFMO is an interesting story, which I'll tell you about, and also with this other drug, which I'll tell you about. So if DFMO or eflornithine, I've mentioned to you already that this is given to patients in combination with nifurtimox in the next study, and this, in fact, is much improved. In fact, the death rate is about 0.7% compared with 5%. So this has been an advance. The problem is this does not work in rhodesiense. This, in fact, is an ornithine decarboxylase inhibitor, and it's static and not cidal. And it was shown to be effective in the 1980s for gambiense. It became an orphan drug. Certainly in Europe, an orphan drug is if it's less than a certain number, and it became very expensive and non-profitable. And what happened is Médecins Sans Frontières, combined with WHO and Aventis, as it was then known, and also Bristol-Myers, got together, and actually, as I recall, Bristol-Myers made something called Vanicor, which is a facial hair remover, and this actually has got DFMO, and something like many doses were made available, and so this was brought back for second line therapy, for initially second line, then first line, and then this advance showing that if you combine it with nifurtimox, is much better. So can you prevent and can you ameliorate? So this just shows a typical experimental paradigm. Amelioration, it does both basically. So what you do is you produce this PTRE, and then you give eflornithine, and then you can make it even worse if you do it at 42 days. And this is what you get. If you look at the top one, if you will, you can see the pathologists amongst you that there's difficult for me to see without getting vertebrobasm sufficiently, but basically, you can see that there is a meningeal reaction there, and then if you treat, what happens is you can see it's gone. And you can also see these cuffs, you see that? They've gone. And that's astrocytes, and you can see the astrocytosis goes. So this not only prevents, but also ameliorates. Substance P, the way I got into this is that when I was at NIH in 1993 as a faculty scholar, and Susan Newman, who was an extremely eminent pharmacologist who discovered the 11 amino acid sequence of substance P and also discovered neurokinin. And she had this antagonist, and she said, look, do you have a CNS inflammatory disease I can test this in? And of course I said yes. And therefore we tried it. You're familiar with substance P, of course, because it's involved as a neurotransmitter, involved in pain, but also it's involved in immunology. And if you look, it stimulates IL-1, TNF, IL-6. These are the things that I've already mentioned. So we thought maybe if you gave this antagonist in our model that you would produce some amelioration. And basically, this is what we used. This Rompulonc non-peptide specifically binds the NK1 receptor. To do this, we had to devise a semi-quantitative scale. We can do this both for pathology and also for clinical. And this allows our statistical expert, George Gettenby, who's a mathematical modeler, to me, complex statistics. I'm sure it's easy for him to work out whether or not there's an effect. And this is the grading scale which we developed, very simple. And basically, we published this in PNAS over 10 years ago, and we showed, in fact, that that this did significantly reduce the neuropathological score, and also the astrocytosis also goes down as well. And also, in fact, the knockout story is very complex. We published it in Brain. You can see the paper there. But essentially, what you do is, when you take with the NK1 knockouts, what happens is they're clinically slightly better. So they are clinically improved, less die. It's very complex because the neuropathology got worse, and we had to do all sorts of experiments to show how that occurred. But the main thing is they're better. So this summarizes basically that azathioprine it prevented but didn't ameliorate, and DFMO did all three. So it's not really surprising. And also the substance PI antagonist. We were thinking about using this potentially as an adjunct therapy for sleeping sickness, and I had actually discussed it with people. There was a little bit of enthusiasm, but then we came up with something else that I'll tell you about later on. Now, just to mention the blood-brain barrier, there's tremendous interest in this, and this is really very much my current interest in the experimental model. Chris Christensen very kindly just sent me a message to say I could show this. This is from his JCI paper. And basically what he found, he got interferon gamma knockout mice and to see what would happen. And what actually happened is, this is a diagram, this is a cartoon, and if you just look at that, this is the endothelial basement membrane, and that's the parenchymal basement membrane. And what you see is these trypanosomes caught. And what he found is they got stuck. This was a great interest to me because to me this is a model of the intermediate stage. So these are where you potentially might treat with early stage drugs. And this, just keep your eye fixed on that. I'm now going to advance the slide. Now that's what he really saw. Okay, and this red is the trypanosome, and these are the two layers. So that's just what he saw. He also showed that alpha-4 laminin was important and not alpha-5. So this was a beautiful demonstration of the way in which the traversal of the trypanosome, which is the key point in the CNS disease, can be dependent on interferon. Okay. Now, I put this together for an article in Journal of Clinical Investigation. This is the simple version, okay, as far as I'm concerned. Basically, all this is meant to show, I mean, some of it's a bit out of date, actually, but basically what I try to do is show there are three aspects of this. You've got all the stuff that the trypanosome is doing in terms of interferon gamma release. You've then got parasite components, like VSG, as I mentioned, interferon, which activate macrophages, and then you have the toxic effects of those cytokines on the brain. You've also got the more direct effect of the trypanosomes. For example, the Christensen's group with colleagues has also showed beautifully that that the suprachiasmatic nuclei of the hypothalamus, these are the areas that are concerned with circadian rhythm. They are abnormal. Not only are there neurophysiological changes, but also there's altered MHC expression, and they can find changes in that area. Highly significant because they're the areas that control sleep. So that is the basis, we think, the pathophysiological basis for the sleep disturbance. Furthermore, there's this other thing here, and of course that's related to this, which is all these other things going on as well. Substance P is clearly important. By the way, substance P has also been shown to be important in the generation of inflammation in other diseases, malaria, toxoplasmosis, HIV. So, I mean, this is a general thing. And then we think there's this balance between counter and pro-inflammatory responses, and that influences the brain. So that's what I think is going on, and I think that people are still using this, so presumably something must be right.